Welcome to Mad Medicine with Miss B. Today we're just going to do a quick little minor EKG brush up or introduction, and I'm hoping this works. I figured if I tilt this, I don't know, my God, this is awful. I'm so not set up for this. If I tilt my daughter's dry erase easel, you can see what we're talking about. Real quickly, just a little introduction. I know LPNs don't get too involved in this, so we're just going to talk about this a little bit to get a basic idea of what an EKG looks like. Now, remember, when we've got that 3 lead on, or even the 5 lead, we're just kind of taking a view of the electrical activity of the heart. So what we're looking for is the path that the electricity takes through the heart, which creates a rhythm, which while printed out looks like hopefully this on paper. So even with the 12 lead, the way I kind of describe it, whether you have 3, 5, or 12, is it's kind of like looking out of a window and getting a different perspective. So if something was going down at my front gate, and I looked through my front window, Bailey looked through his front window in his bedroom, my daughter looked through her bedroom window, and my husband was on the other side, and someone was looking out the patio. We're all looking at the same thing. We're just getting kind of a different aspect or view of that electricity going through the heart. So that's what the different leads mean and placement. So we're just tracing the electricity. And I always describe it as kind of like when you, let's say a small child comes home after school, and every day he puts his stuff down and takes the same kind of trek through the woods to his grandmother's house, where she helps him with his homework and makes him, cookies and milk. Well, if during that same trek he creates this path and a tree falls across that path, he still can get to where he's going. He's just going to go around it. So if there was dead tissue like a tree down in the middle of his path, he could still get to where he's going, hopefully, if there's other paths to take and there's no significant other dead trees down, he can still get there. It's just going to be a little bit different of a path through the woods. And this is kind of what it is. It's a path through the woods that we trace via electricity onto paper. So what we'd like to see is a P, QRS, and a T. A P, a QRS, and a T. So the P wave means that the SA node is firing. It doesn't mean that it's normal and everything is fine. It simply means if you have a P wave that the SA node fired. It could be in a bad situation, or it could be in a regular rhythm, but the SA node simply means that it starts where it should. It could go downhill from there, or it could be just fine. So your P and then your QRS is kind of like your AV node, bundle of His and Purkinje fibers, all firing in consecutive order. And then the T wave is repolarization or resting, allowing that muscle to rest, regain, to do it again. So you have to have that resting phase, or that muscle can't fire again. So this is what we'd like to see. Real simple, real basic. This is going to be a long video, but that's what we'd like to see. So the SA node firing at top, sending that message to the AV node, jumping to the bundle of His, and then through the Purkinje fibers, allowing that to contract and spit that blood out of the atriums, through those valves, into the ventricles, and then the ventricles will compress and send those out to those arteries. Sorry. So in aspect, what I mean by things could go south or things can be just fine is that when you have a P wave and that distance between your P and your QRS is altered in any way too short or way too long, or systematically damaged, then you're going to see a change. Like for this instance, and I should have labeled it, like this, for instance, is first degree AV block, which is very common. We see it a lot. I even kind of quit printing it out to send to you guys so you could see it, because it was so frequent that I had so many. I didn't even need any more. Total viable rhythm doesn't mean that there's anything wrong with the heart, but for whatever reason, there's a hesitation from the SA node to the AV node and then sent to the Purkinje fiber. So for whatever, and the bundle of His. So for whatever reason, that message is being delayed. Still a viable rhythm, still no problem, still completely workable, doesn't need any medication or follow-up. It's just a delay. Now you can also have periodic delays, which is like what we call a sinus arrhythmia. There's a P wave, there's a QRS, there's a T, there's resting, everything looks fine, but there's just some abnormality. Like these don't march out, like you can kind of measure them out and then there's a hesitation. Or there's PVCs where there's additional beats, like there's patients forever telling me that, well, my heart skips a beat. That's not a thing. I don't stop telling me that. Every time I talk to a patient on the phone, they're like, I said, have you ever seen a cardiologist for anything more than just a checkup? Like, well, yes, the doctor says my heart skips a beat. Which beat is that? What's the name of your arrhythmia? Oh, there's no name because there's no such thing. Okay. I don't know what skipping a beat means. And it doesn't, there's no effect to that. And that's what I'll say. Did they put you on any medication? Did you have a workup? Yeah, everything was normal. Okay, well then stop telling me people that, because it doesn't mean anything. That's not even a term that we use. Or PVCs, they say like, I have palpitations. Yeah, that's very common. Do you take medication for it? Were you ever symptomatic? No, I can just, feel my heart beating from time to time. Yeah, so can we. That's usually PVCs, which is a premature ventricular contraction. So right where we should get another beat or just before, you'll see this big, ugly, erratic, kind of chaotic, little wide complex, what we call an ugly beat. And it doesn't, really mean anything either. So it's just a premature ventricular contraction, also very common. If they came frequently or interfered with the heart's functioning and cardiac output, stroke volume, then you might have a bigger issue. But for the most part, it's not that big of a deal, and they're very common. People don't even know they're having them. I could look on the monitor and tell this patient all the time. I can't tell you how many times I've hooked a patient, or all of us, we've hooked a patient up to a monitor, and we're like, what kind of heart history do you have? Who's your cardiologist? We're like, what? No, I don't have any problem. I'm like, you do. And I'll run and get an anesthesiologist, and we'll either cancel the case or, kind of try to figure out what's going on, see if he's symptomatic, see if we can't get a previous EKG from his primary or something to compare to see what's going on. But it's happened. And you that have taken my IV therapy course, I've passed those rhythms out and have shown you on paper how this one guy couldn't even choose a rhythm. He had 50 different rhythms in one setting. My mouth dropped. I went and got an anesthesiologist who decided that, he was fine. He was completely asymptomatic. And of course I said, who's your cardiologist? What kind of problems do you have? No, I've, never had any issues. I'm like, never in your entire life? You had never had any issues? No. Then the anesthesiologist comes over and asks, and suddenly they had rheumatic fever as a child. Couldn't have told me that, right? I'm just the nurse. What do I know? And then I go get the doctor. And then, of course, the anesthesiologist looks over at me and gives me this, you're an idiot grin. And I'm like, darn well he didn't tell me that, because I would have told you that. But at any rate, then we have a full conversation in just faces. That's how we do. Dr. T and I can do that. So and there's a million other rhythms, and that's just it. There's, probably at least 10 different rhythms that I can show you on here. And maybe I'll even do that in another one where I can draw each individual rhythm and kind of give you an idea of if you've heard the term junctional, if you've heard the term second degree AV block type 1 or type 2 or complete heart block, third degree heart block, if ever you've seen those. And I've gotten that also. I had a sweet little nurse anesthetist, and I told you guys this before. I'm getting ready to, I'm going to take one more patient in PACU, and then I'm going to leave for the day. And, Trish is like, oh, well, I'll take him. I'm like, no, I'll get it. I'll take this last one and then I'll go. And the CRNA that's wheeling in with this patient, she's kind of looking at me and going like this. I'm like, what? I'll take this last one and then I'll go. And she's like, no, you won't, because she knew darn well, but she didn't want to give up the beans until whoever decided to take them knew that they were going to have to deal with this. She locks the bed, looks up at me and says, he's in complete heart block. I'm like, I'm sorry, come again now? He's in who to the what now? He's in complete heart block, which means there's like a P wave, a QRS, a QRS, then a P. There's no rhyme or reason. His SA node and AV nodes are like, I don't know, is it my turn? Is it your turn? Is it mine? Should I go? Should you go? Did you? No, I just went. No, I just went again. I did. Are you going to go? Because I just went again. There's no rhyme or rhythm. How this guy was completely asymptomatic, other than the fact that he was 100 years old, and I was maybe so used to it because nobody ever checked in or he never had any sort of stress test or, I don't know, EKG, complete heart block. Fortunately, he was completely asymptomatic. We transferred into the ER. I think he maybe stayed overnight. Hopefully they put a pacer in. I'm assuming a dual chamber pacer. I don't know. At any rate, you're not always symptomatic. So that's kind of part of the problem. And then, we can also probably go into a little detail with cardiac arrest. I need to do that. We need to talk about cardiac arrest versus an MI and how they're not always related. At any rate, so this is kind of, the basics. So I drew a couple. So we've got the first degree AV block, super common. The other very, very common rhythm you're going to see is AFib. And you're like, super common? Yeah, very common. So when all of you, want to immediately report it to me, and I'm like, yeah, I know he's in AFib. He's, being treated for AFib. He lives there. That's okay. He's on the golf course with AFib. She's shopping with AFib. People walk around with AFib all the time, as long as they're treated. What are they treated with, you ask? Good question. Clearly, they're going to be on a antidysrhythmic, let's hope. And more importantly, don't say it. Don't say it. I'll come after you. An anticoagulant, something to decrease the likelihood of the blood that's pooling in these atriums to coagulate and then drop a big old nasty clot into one of these ventricles and send it either to the lung or out to the body where it can reach the brain or the heart, right? We don't want those things. So in AFib, you'll notice no P wave, not much of a T or resting, because there's no rhyme or reason. The atriums are quivering uselessly, kind of like your husband around the house when you're not home, just watching football, scratching his genitals, hanging out, doing absolutely nothing, even though you left a list. Quivering uselessly, doing really nothing at all. And the atriums are kind of in that same phase that, should we go? I guess. Okay, we'll pump pump again. I just pumped. We'll pump again. Well, now there's no rhythm. There's no marching out. There's no rhyme or reason. They're too close, too far, too close, too far. The rate changes between, 79, 88 to 110 and then 114 and then 92. Because your EKG is counting this 6 seconds and then those 6 seconds and then that 6 seconds and then that 6 seconds. So it's constantly changing every second, recounting the next 6 seconds. And you're always going to get different numbers because there's no rhyme or reason. And it's going to times this by 10 and then this by 10 and then this by 10 and then that by 10. So you're going to get like 40 over here, but you're going to get 75 right here. So there's no rhyme or reason. The atriums are quivering uselessly. The ventricles are having to do all the work, and there's only so long that may work unless you can get the not just the rhythm, but the rate under control. So a rate controlled AFib are the people on the golf course and that sort of thing. Their atriums aren't going to fire, even if you put in a pacemaker, if they have, sick sinus syndrome or the SA node is so shot, you can fire it at all you want, but that electrical current is not going to move. So you just have to kind of deal with the fact that the atriums are not going to, they're not going to constrict. They're not going to flex at all. They're not going to spit that blood correctly through those valves. So it's going to kind of drip through as it feels so. And the ventricles are going to do all of the work. So the ventricles, that QRS, so the AV node, the bundle of His and Purkinje fibers are the ones that you're going to have to kind of keep rated and keep working well, either with a medication, that those patients usually that are on your calcium channel blockers, your DIGs, your amiodarone. And as long as that rate is controlled and their cardiac output isn't damaged and their stroke volume is decent and they're not symptomatic, they can live in AFib as long as they're on those two medications, and hopefully they are. Now, if ever you've seen an AFib patient that's not on an anticoagulant, and I have quizzed you as a student on the floor, why wouldn't this patient be on an anticoagulant? You have to look for the common sense questions. Why wouldn't this patient be on an anticoagulant? Have they had a previous bleed, a GI bleed, a brain bleed somewhere that it's not worth? The benefits do not outweigh the risks. So that may be why they're not on it. So kind of look for those things and make it make sense. So kind of in a nutshell, and anything under 60 is bradycardic, anything greater than 100 is tachycardic, and that's just kind of a rate name for the rhythm. But the actual rhythms, whether it's first degree AV block, second degree, type 1, type 2, third degree, which is complete heart block, you've got a junctional rhythm, you've got AFib, you've got a flutter. If I thought about long enough, I can come back, or God forbid, SVT, or torsades. There's a bunch of others, but things that you're going to see most often are probably these. If I can, maybe next week we'll do a little Winky Bach. Maybe I'll show you a couple of those. I've actually seen those, and they're so neat because as soon as you see one, you want to immediately print it out and show somebody when they're so textbook on actual paper from a patient's heart, the way you've seen it in a book or the way you've seen it in a class. It's really neat to see that is literally how it goes. It gets longer, and then falls off, and you're like, oh my gosh, there it is. And sure enough, it's gone, and you kind of start all over. And the girls that taught this to me, shout out to a little Tracy and Mary. You guys are fabulous over at the local hospital here. They really explained it well, and Tracy did a great job kind of explaining how there's a relationship between the husband and wife here, and when the atriums and ventricles quit communicating via electricity, then everything goes to crap, and that's the darn truth. So that's probably not the best explanation, but that's to kind of keep these short. That's kind of the best it's going to get. So for today anyway, because I have, as always, 100 things to do because I am so freaking busy. Once upon a time, I worked, I don't know, 40 hours a week, 5 days a week for almost 30 years, and I have no spare time. So not that I'm out of pet peeves, like I said before, but I'm just I'll end it with cute little things that people say. I did buy the shirt though that says "Mama, Mommy, Mom, Bruh," because that's or dude. It should say dude on there, but it does say bruh. I will tell you, I'll end this instead of with the pet peeve with the adorable little thing as a patient charted on her actual sheet that she sent into the doctor that they send to us when we get them ready. She had her gallbladder removed. I'm assuming the silver one is still in place, but that gold one, it's out. It has been removed. There is no gold bladder anymore. And that sweet little lady. She was adorable though. And she reminded me of a cartoon character. She sounded like the lady from Wedding Singer, you know, the hip, hip, hip and a hop, bang, bang, boogie. Anyway, okay, so that's it. Like always, face your fears, forget your failures, follow your faith. I'm going to try to work on that too. Okay, hugs and kisses. See you next time. I wonder if this will work. You think it'll work? You think? No? You piece of dog.